Polycystic kidney disease, also known as PKD, is an inherited disorder which causes cysts to develop on the kidneys. These cysts can cause complications over time, such as the spreading of cysts to other proximal regions of the body and kidney failure. The cysts are non-cancerous but not benign, and PKD is a treatable disease. There are many signs and symptoms for PKD, but the combination of at least a couple of these general symptoms can indicate the presence of the disease. Symptoms include, but are not limited to, high blood pressure, side and/or back pain, presence of blood in the urine, or a multitude of kidney-specific symptoms such as enlarged kidneys, kidney stones, kidney infections, or kidney failure. If one is experiencing back pain and feels inflamed in the kidney area, it would be a smart idea to head to the doctor's office to have an exam. Many people can go years without knowing they have PKD because the symptoms are often not visible from the outside, so when in doubt, go get an exam at a doctor's office.
There's no definitive test to diagnose PKD, but your doctor is likely to start with a discussion of your medical history, including your menstrual periods, weight changes, and even a physical exam to check for signs of excessive hair growth, insulin resistance, and acne. Your doctor then may recommend a pelvic exam, an ultrasound, or a blood test. If you have been diagnosed with polycystic kidney disease, your doctor might recommend additional tests for complications. Those tests can include periodic checks of blood pressure, glucose tolerance, and cholesterol and glyceride levels. Also, screening for depression, anxiety, and obstructive sleep apnea.
PKD is a genetic disease. It's when the kidneys become filled with cysts, which are fluid-filled sacs, causing them to become larger and larger in size than normal. In the end, the kidneys quit functioning over time. The cysts develop in the outer layer, known as the cortex, as well as the inner layer, which is the medulla, of both kidneys. These cysts are lined with renal tubular epithelium and fill up with fluid and only get larger and larger over time, making the kidneys much larger than normal. The blood vessels that feed neighboring healthy nephrons can get compressed by growing cysts which starve them from oxygen. Perfused kidneys respond by activating the renin-angiotensin-aldosterone system, which facilitate fluid retention and eventually lead to hypertension. The expanding cysts can compress the collecting system, causing urinary stasis, which can lead to kidney stones. The destruction of the normal renal structures can cause symptoms like flank pain and hematuria. Nephrons over time get affected, which lead to renal insufficiency and eventually renal failure. Alrighty, there are two types of PKD. There's the autosomal dominant and the autosomal recessive. Let's begin with the dominant one. The first gene that's responsible for PKD is PKD1, which then mutates in a severe manner. The second gene is PKD2, which is often shown and observed as a less severe disease and is seen much later on, as opposed to PKD1, which is actually seen earlier and it's much more severe. PKD1 and PKD2 actually code for the polycystin 1 and polycystin 2 proteins, which are components of the primary cilium. The primary cilium is an appendage that sticks out from most cells and receives important signals. specifically in the nephrons as a urinary filtrate flows by and is caused to bend. Polycystin 1 and 2 respond by allowing calcium influx, which activates pathway in the cell that inhibits cell proliferation. If either component is absent, that signal to inhibit growth isn't received. This causes cells to proliferate abnormally and start to express proteins that cause water to be transported into the lumen of the cysts, which grow larger and larger in size, compressing surrounding tissue. This is how cysts develop in the kidneys. Continuing with the autosomal dominant information. As expected for a dominant disease, a person who possesses PKD would have inherited a single heterozygous mutation in PKD1 or PKD2. This leaves a functional copy of the gene in every cell of the body, which is enough to produce polycystin 1 or polycystin 2 to prevent cyst formation. Well, how do cysts form them? You see, a random mutation in the remaining good copy of the gene is almost guaranteed to happen in some of the tubular cells as the kidney develops. This second hit, as someone might say, causes polycystin 1 or 2 to be absent and is what impairs normal signaling through the cilium and leads to cyst formation. So, on the level of the person as a whole, PKD shows a pattern of dominant inheritance. However, on a cellular level, it's technically quite a recessive trait. Polycystins are important when it comes to kidney, but there are other places where cysts can occur in other parts. For example, patients or people who have this disease, or not so necessarily, can have cysts in the liver, in the seminal vesicles, and the pancreas. These are usually benign ones. However, this can also lead and affect the vasculature. For example, the aortic root dilation can result in heart failure and have aneurysms of the cerebral arteries in the circle of Willis, which cause the thin walls to rupture and develop into a subarachnoid hemorrhage. In the first slide, you can see the heterozygous chromosome mutation, and in the other slide, continuing, you can see the different parts of the body that cysts may occur. Alright, we've talked about the autosomal dominant PKD. Let's talk about the autosomal recessive PKD. So these symptoms usually manifest in infants. The recessive type is mostly known in infants, as mentioned before, and the other one, the dominant one, is usually present in adults, which is why the dominant one is usually known as the adult PKD disease one. So how does this actually occur? This happens when someone inherits a mutation on both copies of the PKD1 gene, which codes for the fibrocystin protein, which also co-localizes with polycystin 2. It's not exactly clear or explained how. There is a theory, however, that it might be involved in the result of the pathway and calcium signaling describes in the PKD, in the dominant one, the one that I mentioned, which might be a similar mechanism that also cause cyst formation. This cyst formation can lead to renal failure even before birth. So you have a fetus and it's growing inside a woman. The fetus itself is now having trouble to produce urine. And since amniotic fluid comes from fetal urine, fetuses can develop oligohydramnios, which is low amniotic fluid. If amniotic fluid is missing, this could lead to the Potter sequence, because without amniotic fluid, the uterine walls compress the fetus. So imagine the walls squeezing the fetus itself. This could actually lead to physical developmental abnormalities like club feet or flattened nose. Part of Potter's sequence can lead to pulmonary hypoplasia, which is the underdevelopment of the lungs. Since amniotic fluid helps the lungs expand and develop normally, this means that there is an underdevelopment of the lungs, which in the end, we need lungs to breathe. So if the lungs aren't developed properly and accordingly, this can interfere with oxygen and respiration, meaning that the fetus now has a respiratory insufficiency that occurs after birth, which could end up being fatal, and the baby could possibly die because of this. So these are the two PKD forms, the autosomal dominant and the recessive one. So there you go. Thank you.
Tolvaptan is a medication that recommended by the National Institute of Health Care, and it is an excellent way to treat this type of disease for adults. It can be used to slow down the growth of cysts, reducing overall kidneys growth and preserving kidney function for longer.
First up for treatments, we have a new type of pill that is going by the name of JYNARQUE, and this pill is known to be good for polycystic kidney disease because it is a pill that slows the progress and growth of any cyst, and that is what polycystic kidney disease is. For the second treatment, we have another pill, which is not so new, but is called trimethoprim sulfamethoxazole, which is a type of antibiotic that fights off the core cavity of the cyst. And lastly, if this disease is greatly severe to the patient, they would maybe consider kidney removal along with a kidney transplant in hopes that their body doesn't reject it. For statistics, we have three data images, and on the far left of the vertical image, it gives us information on how 1 out of every 500 people have this polycystic kidney disease, and without looking at any other factors, of course, which means that is 12.5 million people worldwide overall who get this disease. And in the top right image, it tells us that those who have this disease and want children have a 50% chance of passing this gene onto their children. Lastly, the graph on the right bottom, it tells us about how in the years 1935 and 1980, through those years there was about 1.3 annual incident rates with polycystic kidney disease, as compared to the years 1981 to 2016, with a 3.1 annual incident rate.